like to introduce the next lecture by Dr. Mona Abdelaziz, the systematic approach of basic fetal echo in normal and high-risk pregnancy.
Hello, welcome my dear professors and colleagues. I'm Mona Abdelaziz, Assistant Lecturer of Radiology at Ain Shams University Hospital and also a former fellow at Magdi Yaqub Heart Foundation. Our talk today is about the systematic approach of basic fetal echocardiography in normal and high-risk pregnancy. We'll start by the normal fetal echocardiography technique and its proper timing. The proper timing for the fetal echocardiography to be performed is between 18 to 22 weeks gestation. First, we should determine the situs. To determine it, we should check for the fetal head and the spine. The stomach and the cardiac apex should be at the same side. If there is right to left inversion, it's what's called situs inversus, where the cardiac apex and the stomach became on the right and the liver is seen on the left. And the term situs ambiguous is used to describe anything other than the normal and other than the situs inversus, and usually associated with right isomerism and left isomerism, which is usually associated with complex congenital heart diseases. This is an axial ultrasound image of a third trimesteric fetus. Show the situs solidus. The stomach and the cardiac apex are shown to be on the same side. Here's the stomach and this is the cardiac apex. Second, we can determine the heart position at the four-chamber view. The normal heart is situated at the midline and the apex is directed to the left. This is an axial ultrasound image of a fetus at 19 weeks gestation. To determine the heart position, we should draw a line. This line should bisect the chest from the spine to the sternum and passing through the fetal heart. This line should pass through the right ventricle and the left atrium, and any subtle changes in the position or the axis may be the first indication for congenital heart disease. And then we determine the cardiac axis. The normal cardiac axis in second and third trimester is normally ranging from 30 to 45 degrees, and in the first trimester it is a bit higher, from 34.5 to 56.8 degrees. This is an ultrasound image, axial ultrasound image, that shows the cardiac axis at a 19 weeks gestation at a four-chamber view, which we'll discuss it. We'll talk about it later. We draw, to determine the cardiac axis, we should draw two lines. The previously mentioned line, the white line that bisects the fetal chest from the spine to the sternum and passing through the right ventricle and the left atrium, and another red line passing through the plane of the interventricular septum, and the cardiac axis becomes the angle between these two lines. And any abnormal cardiac axis is usually associated with conotruncal heart diseases. Second, we'll talk about the basic views of the fetal echocardiography and another additional views. The basic views are the four-chamber view, the left ventricular outflow view, and the right ventricular outflow tract view, and there are other additional views like three-vessel view, three-vessel trachea view, and bicaval view. First, we'll talk about the four-chamber view. The four-chamber view is used to identify the ventricles, the atria, and the atrial endoventricular septa, the AV valve offsets. First, we can identify the ventricles by its interior contour. The left ventricle is usually smooth in contour and has no septal valve attachment, while the right ventricle has a trabeculated contour and has a specific landmark, which is a moderator band. We'll see it in this slide. This a fetus with a four-chamber view at 28 weeks gestation. So the RV, the right ventricle, is lying directly directly at the chest wall and contains a moderator band, which is a specific landmark of it, for it, and has a trabeculated contour, while the left ventricle had a smooth contour. And we can measure the width of the ventricles at the level of the AV valves. Here's we can measure the width of the left ventricle at the level of the mitral valve, and we can measure the dimensions of also of the right ventricle at the level of the tricuspid valve, and they should be equal, nearly equal inside, and both should be apex forming. Second, we can determine the atria. The identification of the atria also is done by the four-chamber view. We determine the atria by the drainage of the veins inside them. Here we can determine the left atrium by the drainage of the four pulmonary veins inside it, which are determined by this white arrow. And while the right atria couldn't be seen on this plane, it is better to be assessed on the bicaval view. The drainage of the superior vena cava and inferior vena cava into the right atrium will be shown on the bicaval view better. This is another axial image to show the foramen ovale at 19 weeks gestation on the four-chamber view. It's here represented by this white arrowhead. As a defect in the atrial septum, and we can see the movement of the foramen ovale flap moving with the atrial contraction. This for the assessment of the ventricular and the atrial septum. The ventricular septum is represented here by the white line, and the atrial septum is represented here by the red line, and they are approximately, the ventricular septum is approximately twice the length of the atrial septum, and if they are more or less equal in length, we should think of a common atrioventricular valve or atrioventricular septal defect. Here is another ultrasound image that shows a pitfall of the four-chamber view as a normal transition from the muscular to the membranous septum results in a signal dropout, which is represented here by these arrowheads, and can be mistaken by presence of VSD. But on the right image here, the angle of inclination is changed, and the pin become perpendicular, and it's shown that the ventricular septum is intact without any VSD, and we should check also by color Doppler imaging to see if there is any possible VSD present. We can see also on the four-chamber view the AV valve offset. Here's the mitral valve belongs to the left ventricle, and the tricuspid valve belongs to the right ventricle and is more apically placed than the mitral valve. And the septum together with the AV valves forms the cross of the heart. On the area behind the heart, we can detect at 18 to 20 weeks gestation, we can identify only identifiable tubular structure, which is the descending aorta, and is seen touching the left atrial wall. While on a more advanced age, if another tubular structure appears, it could be the esophagus. Here's an ultrasound image of a fetus 19 weeks gestation. There's a single vessel that is running closely behind the left atrial wall, which is the descending aorta. We'll talk about the outflow tract views. First, the LVOT. The LVOT is formed by the aortic root and the trunk and runs in the posterior mediastinum. Here is an LVOT view. We can see the ascending aorta arising from the smooth walled ventricle, which is the left ventricle, and is not branching as in the RVOT. The pulmonary will branch and will give rise to the ductus arteriosus, and then to its main branches, the RPA and the LPA. The RVOT, as we mentioned, is formed by the pulmonary conus and the main pulmonary artery, and it will give the ductus arteriosus, which connects the pulmonary to the descending aorta in the early fetal life. To imagine this axial image, this axial ultrasound image, we can see its corresponding CT image, as here the ascending aorta is hugged by the RBA, and this is the main pulmonary artery. The main pulmonary artery here gives the ductus arteriosus, represented by this small arrow, which connects the pulmonary to the descending aorta, and here is represented by this blue rectangle at the CT image. We'll talk about other additional views, the three-vessel view, three-vessel trachea view, and the bicaval view. First, the three-vessel view, it's another way to look to the outflow tracts, and it's obtained by sweeping toward the fetal head from the axial four-chamber view, and we should look for the size of the three vessels. The superior vena cava is usually smaller than the aorta, and the aorta is smaller than the pulmonary, so the pulmonary is the largest of the great vessels. Here's an image to show the cut planes for, or the approximate scan planes for the three-vessel view and the three-vessel trachea view. Here's the red line representing the three-vessel view cut, and the blue line representing the three-vessel trachea view cut. To obtain this axial image by the arrangement of the vessels, pulmonary, aorta, and superior vena cava from above downwards. The three-vessel trachea view, it includes additional views for the trachea and the esophagus, and is obtained by sweeping superior and toward the left from the three-vessel view. And on this view, we can see the ductal and the aortic arches forming a confluence, a V-shaped confluence, and is separated from the sternum by the thymus, as we will see in the next slide. This is an ultrasound image that shows the normal three-vessel view. Here we can see the trachea, this small tubular structure behind the vessels. This is a normal arrangement of the vessels, the pulmonary, the aorta, and the superior vena cava. And here the aorta and the ductal arches, which is the ductus arising from the main pulmonary, forming a V-shaped confluence. And the direction of the blood flow should be on the same direction, because it's, if it's reversed at one vessel, we should think of a duct-dependent congenital heart disease where the flow is reversed from the pulmonary to the aorta, not from aorta to pulmonary. Here's another ultrasound image for the three-vessel trachea view. Here is the trachea, and here is the thymus seen in the anterior chest wall. This is a normal arrangement of the vessels, the pulmonary, the aorta, and the superior vena cava. Here is the confluence of the aorta and the ductal arch, which arises from the pulmonary artery in a V-shaped manner, and the flow should be in the same direction. Here is the azygous vein draining into the superior vena cava, and two tubular airfield structures, which are the trachea and the esophagus, and the thymus is seen at the anterior chest wall. The bicaval view, the parasagittal view that show the drainage, as we mentioned before, that show the drainage of the superior vena cava and the inferior vena cava into the right atrium, and should be similar in size. Also, on the same plane, we can see the hepatic veins in the liver and the drainage of the IVC. This is a bicaval view for a fetus of a 19 weeks gestation, showing the drainage of the superior vena cava and the inferior vena cava into the right atrium. And we can see also the hepatic veins represented by the arrow within the fetal liver. And our study at Ain Shams University Hospital, we have this study and in some private centers, and we take a sample of normal and high-risk pregnant females, 30 normal and 30 high-risk diabetic and hypertensive patients, and we use the color Doppler ultrasound machine. And we take the normal cardiac parameters, the basic approach, the upper abdominal view, the four-chamber view, LVOT, RVOT views, and three-vessel view. And we have a data acquired from the previously established views, which is the cardiothoracic ratio, the position of heart, apex axis, number of valves, AV and VA concordance, sizes of atria and ventricles, atrial and venous connections, and heart rate. And we include in our study the normal and the high-risk pregnant female in the second trimester with a single pregnancy between 18 to 50 years of age, and we exclude the first and third trimester, twin pregnancy, and severe poly or oligohydramnios patients. And our results were that we can't find any statistically significant difference between both groups regarding the longitudinal diameters of the left atrium, right ventricle, while there is only significant increase in the LV diameter in normal compared to high risk. It's higher in high risk group. And there is no difference between high risk groups, either diabetic or hypertensive groups. Thank you.
It's a very good presentation. برافو عليكي. thank you very much for this. اقول لك بس يعني اتب كده لو تسمحي اقولها لك. في المحاضرات اللي بتقال فيها فيتال ايكو اظرف حاجه تشدي بيها الناس انك تحطي سيني لوبس فيديوز اكتر منها صور. ما اعرفش تتفقوا معايا، الهارت از دايناميك اورجن ودايما الفيديوز تبقى اشيك كتير. يعني الكدني مثلا مش فارق نحط صور من فيديوز، انما في الهارت عايزه تبقي البرزنتيشن جذابه اكتر، حط شويه سينيز كده مع الدوبلر مع البتاع، هتلاقي الدنيا الطف كتير. بس محاضره هايله، برافو عليكي.